Hi everyone, it's our Tell All Tuesday, and I'm here with one of my favorite REs, Dr. Vasiliki Moragianni, who left me, who moved away, and we're going to talk about that. But we're excited to have this conversation about PGD, and I'm looking forward to learning all I need to know about that from Dr. Vasiliki. So hi, Dr. Vasiliki, who moved away to Virginia.
Hi, Kristen. Hi. Hello from Fairfax, Virginia.
I
used to be closer to you in Boston for many years, and we moved just this summer, and it's been tough on many levels, but it's also really exciting to be in a new place. I'm now at the Genetics and IVF Institute, which is one of the premier and oldest fertility centers in the country. We are in Fairfax, Virginia, and we provide, as the name implies, both genetics and fertility services. So PGD is right in the epicenter of exactly what we're dealing with on a daily basis with a lot of our patients.
Well, it was interesting, and I'm gonna have to talk about this, but I was talking to another holistic provider in the Boston area. So Virginia, our loss is such Virginia gain, because you've left such an amazing space to feel here, because your practice is just so holistic and understanding and calming. So I'm so grateful to be sharing where you are, your new home, and wishing you well.
Thank you.
So here we are, you're in Virginia, and the genetic services. And I know you know my story, so I was, they wrote on my chart older mother because I was 35 when I was starting, and had Cole, and 40 and pregnant, Vasiliki.
Right.
So what is PGD?
Okay, so PGDs, first of all, let me take a step back and clarify. There's something called PGD and something called PGS. So the PG part stands for pre-implantation genetic, and it's either diagnosis or screening. So pre-implantation, just taking a further step back, in IVF, both of these techniques are only available with IVF. And IVF means that a woman will take medications, injections of medication to stimulate her ovaries to produce eggs. These eggs are retrieved from her body, from her ovaries. They are in the lab fertilized with sperm. They are then, that's how embryos develop, and embryos are cultured or watched until approximately day 5 or 6 of development, at which time they're either transferred back into the uterus of the woman or of a gestational carrier, depending on the situation, or in the case of PGD or PGS, they are a very, very small sample of the outside layer of the cells that will not become the embryo itself, but will become the placenta and the supporting structures. And a biopsy that for the most part does not compromise the embryo is performed. The embryos are then typically frozen. We get the results back from that biopsy, and then in a subsequent cycle, the embryos are transferred back. So it is, again, pre-implantation, so before the embryos are transferred and implanted into the uterus, genetic, because we're getting information on genes and chromosomes for these embryos, and it's either diagnosis for PGD or screening for PGS. The difference between the two, and it's not always clear to patients, and it doesn't have to be, the technology is the same, but the question is, or it's very similar, the technology, the question is, are you just broadly looking for any changes in chromosomes, and this would be indicated, for example, in somebody who is a little bit older, maybe over age 35, which isn't old, but it could be considered older for fertility standards or reproductive standards. Somebody who has had a lot of miscarriages, 2 or 3 or above, and no specific reason for them, or somebody who has had a lot of failed IVF cycles in the past. So this is where you're just blindly looking into any changes in the chromosomes, making sure there are no problems. PGD refers to a case where one or both of the parents or the egg and sperm sources are carriers for a genetic disease. For example, people might be familiar with something like cystic fibrosis. So if both parents are carriers for cystic fibrosis, then we can create at the Genetics and IVF Institute a test specific for the mutation or the change in the chromosomes that the mother and the father carry. This does not exist for any other couple out there. This is unique to them. So we create a test that looks for that specific mutation in the baby. And when somebody is a carrier, it's usually not a problem for most diseases. But when somebody inherits both of the incorrect copies from each parent, then they could have the actual disease. And that can be very devastating in a lot of cases. So before we even transfer those embryos back, by the test, the special test we have created specifically for that couple, we can make sure that the embryo does not have the disease itself. And therefore, we would transfer back only either normal or carrier embryos if it's okay with the couple.
That's so informative, and I so appreciate that. So if you know within your couple's medical history, then what I believe, what I heard you say is that that couple can come to you with whatever medical history that might be of concern.
Right.
And then a specific test could be created for that unique situation.
Right, exactly. And this can go back to something people are becoming more familiar with thanks to celebrities such as Angelina Jolie. So things such as the BRCA mutation, right, or BRCA mutation, which makes some women more prone to certain cancers such as breast, ovarian cancers. So if a woman is a carrier for that, and she would like to not pass the information, this mutation down to her offspring, we can select against this specific mutation. Other cases, the patient, for example, we have a special program for Huntington disease, which is a very devastating neuromuscular disorder that starts later on in life. If there is either a family history and the patient does not know or does not want to know if they're a carrier, we can perform these tests for the embryos without the patient finding out if they don't want to for themselves, but we can make sure whether they're carriers or not, that the embryos we transfer back are healthy and unaffected, which is extremely important because genetic diseases can stop there in that generation. They don't have to continue.
That's amazing. I saw a blog quote the other day about it's not your grandmother's IVF, and
right.
This week alone, I was called a granny this week. No. So I hope I'm not looking my age, but it's so the time right now is so incredible, isn't it, Vasiliki, about the advances and healing and I remember, just really thinking if I wanted to have amniocentesis because it was such, for me, it was such a struggle to decide. Mm-hmm. And what you're saying is, and am I correct in my understanding that this would be after the embryos have gone through the testing, the mom or the woman would go through another IVF cycle for the transfer?
It's not exactly an IVF cycle. It would be what is called a frozen embryo transfer. So we're not doing anything to her ovaries. We prepare her uterus only with a much milder, less involved type of cycle. So once her uterus is ready, and she can sometimes do that even without medications, once the uterus is ready, then we take embryo number 5, which was the normal embryo, not affected by the disease or just normal in the case of PGS, and we transfer it back into her uterus, and then she just awaits the pregnancy test. So it's not a full IVF cycle, but it typically does not happen right after the embryos are biopsied because we need to get a result, and we need her uterus to become ready in a new menstrual cycle.
So that's an important conversation, because then going into this, that it's a 2-month process as opposed to that 1 month process.
Absolutely. Right. And the reason, even though we're actually pretty unique and proud of ourselves in that at the Genetics and IVF Institute, we perform the biopsy in-house, so the embryos or the cells never leave our lab. However, we still need a few hours to get the results back. So if we biopsy on day 5 or day 6, we do not feel comfortable to transfer the embryo back when we get the result, even on day 6 or 7, because the uterus is a little bit out of sync from the embryos at that time, so it's not recommended. So we wait a few more weeks.
Right. That makes complete sense. And so Vasiliki, way back when I was doing it, I made such good friends with my embryologist.
Right.
And I would say
friends.
the concern, there's some people and some women, especially in my practice, that, when you say embryos, you're really saying babies, right? and as a peace of mind, I know that your thoughtfulness, there's such an oversight, not oversight, like babysitting the embryos, because they're with you. They're not leaving the clinic. They stay right on site, which is such a peace of mind.
Absolutely. Yes. And it's a peace of mind for me as well, believe it or not. It's very important. These are your embryos, your potential babies, and I'm equally invested in this. So when I hear my embryologist who hands me the catheter with your embryo on the transfer day, and they say, oh yes, I remember I did your retrieval, I fertilized your eggs, I did the biopsy, and I'm thawing them today, that continuity of care is really amazing.
It is amazing, and it's so important for the anxiety, emotional component,
of course,
for the people going through this, both partners, and especially the woman whose body is producing the embryos. There's this organic, already mothering nature that takes over. And I always say to my clients, you're doing exactly what you should be doing as a mom. You're already acting like a mom, and don't feel that if you bring up this concern to the embryologist or to your doctor that, you're out of line, because you're not.
Right. Absolutely true. No, it is very important, and that's why we take this very seriously, and we've been perfecting this again for decades now. So it's something we're very proud of, and just so that the patients know, this should be a technology offered in a lot of fertility clinics around the country, and it's something that is available for different indications. Again, if you've had sometimes when somebody has had a lot of miscarriages, what is called recurrent pregnancy loss, it can be very, very frustrating. You don't know. We do some basic tests. We don't find a reason. This is one potential. It is not going to eliminate 100% of the issues, but it can definitely offer a potential treatment for these people and help them achieve a healthy pregnancy that continues to term.
So when after my last Vasiliki, I was considered high risk.
Mm-hmm.
And so when you are seeing your patients or your clients and you see someone who has, reoccurring pregnancy losses, is this standard protocol then that you offer them? Because you know what, when you are that woman who has had multiple miscarriages and unfortunately last week I was speaking to a few of my clients that experienced that, you don't, in that emotional state, you're not able to put the dots together to ask this question. So is that standard protocol then?
So not exactly. So I definitely offer it. I discuss this technology with all my patients, just like I discuss IUI and IVF if it's integrated with them. I will offer it to patients. So first of all, you need to talk to every couple or individual separately and figure out what could be the cause of their recurrent pregnancy loss. If the cause of the recurrent pregnancy loss is either an issue with a parent's chronic chromosomes or an unknown reason, maybe PGD or PGS makes sense for them. If the reason for their loss is the fact that there is an infectious process going on in the uterus, or a chronic infection, or a clotting problem, then me checking for the chromosomes and not correcting the clotting problem is obviously not going to be fair to them. So I would offer it typically in cases where we either know of a specific genetic mutation in the parents, or if we don't know, we have exhausted all other possibilities, and this is the only thing I can offer as an increase in the chance of not miscarrying, but not completely eliminating the chance of miscarriages, because unfortunately there's many other reasons that we do not completely understand that can lead to a miscarriage.
Thank you. Thank you for sharing that part. And if we shift gears a little bit, is this also if you want to balance your family? Is this a test that...
Yes, no, I'm glad you brought this up. It's, obviously we are interested in helping patients, and we help patients. We've been helping patients for over 30 years have healthy babies. But some patients come in and they're interested in either family balancing or gender selection. I was going to say that part of the genetic information that we obtain through either PGD or the same with an amniocentesis or a CVS once someone has become pregnant is that the chromosomes contain information on gender. That's how your gender is encoded by your chromosomes. So I will find out if you have cystic fibrosis or if you have Down syndrome or another chromosomal problem, but I will also know if the embryo is male or female. So the couple has the option, or the patient has the option of finding this information out. They or not, they can say, don't tell me, and we will not disclose that to them. They can say, tell me just so that I know, but it makes no difference to me. Or they can say, tell me, and I would prefer to transfer back embryos of such and such gender. And if it's medically appropriate, of course, we will do that. We would never transfer, of course, back an embryo that is chromosomally abnormal, regardless of the gender. But for some patients and individuals out there, even who have not faced fertility issues, it is important to balance their family and also gender selection or gender information really started and is still being done all the time to prevent some genetic diseases, because some genetic diseases are carried in the male or female chromosome, and by making sure, for example, if a genetic disease would only affect the male embryos, then we can find out if an embryo is male, and then this way we can again eliminate the possibility of this genetic disease. So this is the real reason this got started, and now the information is available to patients if they're interested.
I'm glad that we talked about that. And where I was coming from that question was, there's a lot of couples that I'm sure you see and that I have over the past years that they work 2 and 3 jobs to create their family, and they're in the process of assisted reproductive technology, and if they're having PGG, then knowing the sex of the embryos is important also.
Absolutely, right. And again, some people just want to know so that they, just the same way as somebody finds out during the amniocentesis, they're not going to do anything about it. It's just preparing accordingly for a male or female embryo or baby, actually, a boy or a girl. Or for some people, it makes a difference medically, and for some people, it makes a difference socially. Whatever the case may be, this information, once you do PGD, is available. And if you want it, it can become available to you.
Perfect.
Yeah.
So thank you so much, Dr. Vasiliki. Is there anything else that I'm just trying to think in the mind of someone listening to this, what other questions there would be about this as an option? Is it helpful for people to come in with their medical history then?
Absolutely. So first of all, we do not, first of all, patients who have had embryos created in another clinic through part of another treatment, and for whatever reason now genetic testing is recommended or indicated in their case, they can transfer their embryos to us. We can perform the genetic testing at the PGD, and then we can transfer the embryos in the uterus if they've been deemed genetically normal. So this is something important to keep in mind, both for the genetic piece and the gender piece specifically. So you can have your embryos created from another clinic transferred to us, and then we can test them and make them available to you again. And other than that, I think it's definitely very important. Again, there's no generic blanket statement that you can say PGD is indicated for all blank.
Right.
This does not exist. So we take every patient individually, and we meet with them, and we talk to them about their specific needs, their specific desires, what makes sense to them medically and ethically and socially and religiously, and then we take the whole person holistically as much as possible, and we make a decision together with the couple, and whatever is indicated, then we proceed with. So it is absolutely coming in with all your questions and all your medical history and all your medical records is extremely important. And you don't even have to physically be in this area. I do Skype and telephone consultations with patients from all over the world all the time. So you can even get just general information and then decide if this even makes sense for you.
And you know what, Vasiliki, what I love so much about you is you speak so many languages.
Oh, right.
And so this medium of doing a Google Hangout, people all over can view it. So
the advantage of being a foreigner.
Yeah. So, well, thank you so much. It's so great to see you.
It's always great.
I miss you on closer, but I know you're doing your great work, and I'm so happy that we had this little time together. And what was the best way for people to get in touch with you, Vasiliki?
So they can either visit our website it's posted underneath my name, I think, at www.givf, it stands for genetics and IVF.com, or they can call the office at 703-698-7355.
And if they have follow-up questions, they can also email me directly, and I'll pass them on.
And also on Facebook, if they search on Facebook Dr. Moragianni, I have a professional page, and they'll send me questions, and I can easily get back to them.
Awesome. Thank you so much.
Oh, thank you, Kristen.
Good to see you. God bless you. Have a great rest of the day.
You too. Bye-bye.
Bye, honey.